where we reported the results of a randomized phase 2 dose optimization study using CAR T cells for patients with relapsed and refractory CLL. We had already done a pilot trial of CAR T cells for patients with relapsed refractory CLL. And one of the things that we learned is that about 25% of patients would achieve a complete remission. And the remissions, when they occurred, were dramatic. We now, in fact, as of July and August 2020, our first patients are now 10 years out from their CAR T cell therapy in ongoing remission. And so we know when they are effective, they can be dramatically effective. One of the issues was, of course, that it didn't work often enough. When it worked well, but not enough patients were achieving remission. When we looked at the outcomes of our pilot data in our first 14 patients, which had been published several years before this, we realized that we had used a very wide range of cell doses that varied by over a log. There was no obvious dose response effect, but it was a small number of patients. And we really thought to further study CAR T cells appropriately, we need to define an optimal cell dose. So we designed a randomized phase 2 trial where we would compare a higher and a lower cell dose of CAR T cells for patients with relapsed refractory CLL. Our higher cell dose and our lower cell dose were both doses that patients had already received in our pilot trial. They were both doses that had induced remissions in patients on our pilot trial. But the way that this was designed, that we randomly assigned the first 24 patients to either the higher cell dose or the lower cell dose. We then looked at our outcomes, and while it was never designed to be statistically significant, there was a very strong suggestion that patients who received the higher cell dose had a higher response rate. Patients developed cytokine release syndrome, but there didn't appear to be any difference in either the frequency or severity of cytokine release syndrome between the higher and lower cell dose. There didn't seem to be a dose toxicity response. And so the way the trial was designed, after that first randomized cohort, we then chose what appeared to be the most effective dose that was equally as safe, and that was the higher cell dose. And we went on to treat another group of 8 patients. So we had a total of 19 patients who ultimately received the what we considered the optimal cell dose. And in fact, again, while it's very difficult to compare patients across studies and certainly between different clinical trials, we found that if we just looked at outcomes of patients who received what we now felt was an optimal cell dose, 37% of these patients achieved a complete remission. Again, many of these remissions have been sustained for long periods of time. So our overall response rate was just over 50%. Toxicity was manageable. We didn't have any treatment-related mortality. And we found that those patients who achieved remission had sustained remissions. And in fact, any patient who was going to have a subsequent relapse tended to relapse within the first a couple of years. Patients who achieved a remission had a much better outcome. Over half of those patients had progression-free survival, really out beyond 3 and now really close to 5 years. Our median follow-up was long. It was about 2.5 years, so we had a good median follow-up. And one of the things we learned from this is that we think that the dose of CAR T cells may in fact be an important factor for response. To study CAR T cells in CLL patients, we think we identified what we consider an optimal cell dose. It was 5 × 10⁸ CAR T cells given to these patients. And I think one of the important points is response rates were impressive in a very heavily pretreated group of high-risk patients, but also it does show that with detailed study and really trying to understand what the different variables are in responses, we can improve outcomes in this group of patients. as we design our future trials, then we are designing them around what we identify as an optimal cell dose, hopefully improving response rates and obviously hopefully improving outcomes for patients who otherwise really had no good treatment options.